the second episode in the topic specific to practicing in the personal care home setting. I still don't have any conflicts to disclose, so I didn't get a major endorsement deal from my first, oh no, it's still on the screen. How do I get rid of that? Well, that's weird. How do they seem to be going away now. All right, so hopefully these little drawings on the screen are going to go away. But just as a reminder, last week we talked about the clinical frailty scale and how it's relevant to our work in the personal care home setting now and even before COVID-19 changed our worlds. And next week, we're going to be talking in detail about symptom and palliative management of COVID-19 in the personal care home setting. There is now a YouTube link to the first session that was on the clinical frailty scale, but I'll just remind people that if you're watching it live and actively participating, then there is credits for Maine Pro and Royal College. But if you're watching the YouTube version, it isn't, but you can get the non-certified credits if you watch the recorded version. So today we're going to be talking about goals of care discussions and talking in general terms and then specific to COVID-19. So we're going to start again with a case, and this is about Mrs. P, who's residing in a personal care home. She's 92 years old, and her annual care conference is coming up. And in a way, her care conferences have always been virtual because her 3 daughters who are actively involved live in Alberta. They usually rotate so that one of them sees her every 3 months. And she actually usually goes on pass with them to stay with her sister and her whichever daughter is there for a few nights just for a change in scenery. She has severe hearing impairment and her hearing aids only help a bit. She has osteoarthritis and macular degeneration, and she's walks with a 4-wheeled walker and has pretty good endurance. She has a diagnosis of dementia, but it's not impacting her quality of life significantly. She recognizes her family and enjoys time with them, and also enjoys her time with her family at the personal care home. So it just so happens that her annual care conference is coming up. And as I mentioned, the fact that the daughters can't be there in person isn't as relevant for her. So the last time her family saw her was at Christmas, and at that time they did notice, they talked amongst themselves, the daughters did, that she's tiring more easily. She was happy to return to the personal care home, but she still had a great time with all the Christmas festivities. After Christmas, the staff at the personal care home just seemed to notice that she faded a bit, and she was now with the COVID-19 visitor restrictions, she's really missing her friends and relatives who haven't been able to visit. In general, she's still in good spirits, but it's just been a noticeable change. Over the last 5 months, so preceding the visiting restrictions, she's needing more encouragement to eat. She just doesn't seem to have the same enjoyment or appetite. She's now getting more assistance to dress, just seems to not quite have the range of motion or the coordination. And in the evenings, now she's often assisted from a chair. So as she gets tired later in the day, she's needing some more assistance with her mobility. And it's just been noticed that she maybe is a little bit more off with time. She'll make some comments about the time of year that are a little bit off, or she'll be wrong about which meal is coming up. So that sets the scene for our objectives today, which is to identify the opportunities to engage in goal of care discussions, and those opportunities now that we're in a world with COVID-19. incorporate the knowledge of a resident's frailty status into the approach for individualized goals of care and difficult conversations that we have in the personal care home setting, and update our goals of care and difficult conversations in the ways that we now have to update it for caring for people during the COVID-19 pandemic. As with all of these sessions, some of this information is generalizable. So in this week's case, to improving goals of care discussions, but it's going to be important to continue to update the information as we learn more about COVID-19 and as our communities are changing for risks and how we're dealing with it. So please supplement this information with current information, and in Manitoba, that source is often the Shared Health website. So I know that I'm talking to a very experienced audience who, you know, really are experts in many cases in discussing goals of care, and over the years, you know, I've had a fair number of difficult conversations through my clinical work, especially with my dementia work. But what I've been pulling out as I've been watching a lot of the available information about goals of care discussions during COVID-19 is there's always some pearls. So please, I'm talking in general terms, take from it what you will, and it will have been a success if there are some pearls, but I recognize that you all are experts in this area. So as far as the opportunities to discuss goals of care, there are a number of different ways that these conversations come about, and they're often referred. Some of the strategies are the same, but there are different kinds of goals of care conversations. So one very important group of goals of care conversations is advanced care planning. So this is, we think, ahead of when these decisions are needing, trying to set the playbook for how we're going to handle things when they happen. And that's different than when there's a change in clinical status or change in the risk of something serious happening. When we sort of have this conversation needs to have some more concrete decision making and maybe informed by advanced care planning, but maybe right out of the blue. And then there's serious illness conversations. And this is something that there's been a lot of resources adapted for COVID-19 that we're going to talk about. This is when we need to talk about this now, whether we want to or not. And the other sort of half of this is when these conversations are happening. So sometimes these are spontaneous. Sometimes these even catch you off guard as you're passing down the hallway. Sometimes they're part of the routine. And these sometimes have the advantage of being, you can say, we have these conversations with everyone, but we want to make sure that it's current, and then you just carry on with your routine. And then sometimes there's requests to have these conversations. Sometimes that's us as the healthcare team requesting it, and sometimes it's a request from the family. One of the things that I think throughout this presentation is that the spontaneous ones may be most challenging, and it's often okay if it's not too long a delay to say, I just need a little bit of time to make sure I have the information that you need, and sort of changing it from a passing hallway, pull into a side room, into let's schedule that really soon, but make sure it's the best conversation it can be. So all of these different conversations can be in each one of the settings. So we're not using the interactive Mentimeter crowd participation today. I am going to ask a few questions, and I'd be really grateful if you answered in the chat box. I can see that conversation afterwards, and I am trying to gather some of your experiences in the personal care home setting. So one of the questions for the participants is, what's the most common way that you're engaged in goals of care conversations in your work at the personal care home? Do you get pulled into, or are you part of the routine annual, or would there be more of a requested time that works for you and more of a one-on-one with the family, or with maybe the charge nurse? Or do you feel like maybe the conversations are happening a bit late and they tend to be right when we need a decision right now because things are not going well? Your experience would be really helpful to share, and maybe the group would be interested in knowing as well. So as far as Mrs. P's annual virtual care conference, as I summarized before, she's not, you know, quite as robust over the last few months. And I think it's important not to postpone her care conference. And during COVID-19, and with some of the challenges of different team members not necessarily being on site, there may need to be some creativity about how to make these care conferences happen. But especially if there's been a subtle or a significant change in status, this probably can't wait until we fully open up the personal care homes, because we honestly don't know how long that's going to take, and it may be some time. So, you know, this is a time to look at how can we have people safely distanced, and maybe there's some opportunities for exploring multiple people dialing in. And I think this is something that families who are away are really going to appreciate, because they may be feeling like they're really cut off from the care team during COVID-19. They also will be hearing significantly different things from the provinces if they're living out of province and listening to their local news, and will want some information about how things are going in Manitoba. So there definitely needs to be a heads up if there's been a change, so that all the team members are sort of prepared and I'm sure there are routines. We're coming up on the annual care conference. People are making sure that they have current information, but it just may be that the whole team needs to have a bit of a discussion about how things are changing. Because the care conference is an opportunity to review those goals of care in general, and also apply some of the specific information to COVID-19. So just a reminder, in our personal care homes, the advanced care planning goals form is on the chart, and at a minimum is updated annually. And we use the terms comfort care, C, medical care, M, and resuscitation, R. And the descriptors, just if you feel like you'd like to review what exactly is meant by those, is contained in the PPG documents, and the links are there, which I will again circulate the PDF of the slides that have the links. So Mrs. P and her family have indicated in the past that her goals of care are resuscitation, and this has been since admission. She's now been in the personal care home for 3 years, and they have been provided with information about some of the burdens of intensive treatment, but they've always felt she was too good, and she clearly expressed a wish to want to spend as much time as possible with her family and friends. The family have not been able to see her. So each team member is going to need to sensitively describe how she's changed within their scope of practice. And the reason I highlight this is one of the things with families not being able to see them is they want the full picture, and consistency will help families. Now, if there are things that are not consistent, that's important honesty as well. But if things are consistently sort of she's fading or dwindling, then it's helpful for the family to get a picture from different voices, because everybody describes this differently. So in Mrs. P's case, this annual care conference triggers the need for a second conversation more about her goals of care, and to bring in the physician nurse practitioner, and also the family has highlighted that they want to discuss some more information about COVID-19 in Manitoba, and how the measures the personal care home is putting in place to try to decrease the risk of COVID-19. So this is the time for preparing for that second conversation, and it is a team effort. So a few steps that we're going to walk through. Step 1 is updating the situation. Step 2 is updating the information about the resident. And step 3 is just updating your resources, having some additional documents or props at the ready to support you while you're having the conversations. So the situation we're in is that we now have COVID-19 as part of our work and personal worlds. And this wasn't the case during her last annual CARE conference. So the situation includes our understanding of the SARS-CoV-2 virus and the disease that it causes, COVID-19. The situation includes our current understanding of how our patients, and I'm talking about our personal care home residents, are affected by the virus and also affected by the measures we're putting in place to limit the spread of the virus. And I think that's something that's both in the general public's media and also on our minds, is some of the balance measures of some of these safety interventions. Also, and always changing, is the local prevalence of the virus and our clinical capacity to offer different treatment options. So I'm going to try and give you information today that is as current as the last time, within days when I last updated myself on this. This may change, but I'm trying to give you some of the current information that I've been looking at to help with the confidence about the information we're providing to residents and their families about what we know about how COVID-19 is affecting people in the personal care home. So the current treatment for COVID-19 is supportive. There's no evidence-based disease-modifying treatment. And when thinking about frail older adults, even if there is a disease-specific treatment, it's often quite a while later before the treatments have an evidence base in our frail personal care home residents, because those studies just aren't done, and also because the frail are often so much higher risk of any adverse outcomes from any new treatments. So today we are going to be focusing on that supportive treatment and focusing entirely on the benefits and risks of offering different treatment, different intensive or non-intensive treatment options for frail older adults. We are not talking about resource rationing, and I'm grateful that we're not in a situation where we have to talk about resource rationing. So one thing that families are going to be having in the back of their minds is are we writing off the personal care home residents? Are we withholding something because we want to make sure we have ventilators available for young people who deserve it more? And as a geriatrician, I feel quite passionately about this, and am always keeping my radar up for any ageism or ways that things that are appropriate are not being offered. So today we're focusing on the risks and benefits of different treatment options for frail older adults. And we don't have evidence specific to frail older adults with the respiratory disease from SARS-CoV-2 and how they do in the ICU or how they do with ventilation. There just aren't the numbers, or they haven't been published in places that have had higher numbers. So I'm going to summarize some information about what we do know about frail older adults in intensive care settings. So last week during the Frailty Talk, I also highlighted this Bagshaw et al. Study. I'll go into a little bit more detail because this was a study that looked at the outcomes and the mortality outcomes over time for sequential patients admitted to ICU. So this got around the fact that some people were not offered ICU who were frail. This was everybody who was admitted to the ICU. And they did look and found no significant difference in their frail and non-frail population in the intensity of the treatment. Interestingly, they also didn't find any difference in the survival to getting out of the ICU, regardless of whether you were frail. But what they did find is a dose response curve in the in-hospital mortality and then out to 400 days post ICU in your mortality, with an odds ratio of 1.81 for in-hospital mortality for people who were frail compared to not frail. And you can see in the graph there that as you got frailer, your probability of survival got worse, and actually it dropped off quite quickly. So that was a steep initial curve and then sort of flattened out, with the frailest people being 6 to 8. So just reminding you, we're not going to review all of how you assign a frailty scale, but Mrs. P, it has been a 6 or moderately frail since she's been in the personal care home and needed some help with her personal hygiene, and now she's becoming severely frail in the last months from a accumulation of her different deficits. So she's in this 6 to 8, or the blue line, that has poor survivals from ICU for all causes, not specific to COVID-19. Just to reinforce that this is not one isolated study, and I will agree that this is not the most rigorous journal, the Swiss Medical Weekly, although I'm not disparaging them, but they had an excellent summary of the really very good quality journals in this summary of outcomes from different intensive care treatments for people based on their frailty. And the same trend, that the survival, if you are frail, is not as good for all of these if you are, compared to the people who are not frail. So they quote CPR, your survival to discharge if you're frail, 1.8%, whereas non-frail is 31.7. Similar trend for emergency surgical patients, geriatric trauma, pneumonia, sepsis, and then again, this Bagshaw paper is the critically ill patients. Your outcomes are not as good. So this gives us the confidence to say it's not that we're withholding ICU, it's that your I'm phrasing this as a discussion with family, your loved one would not survive or have a good quality of life after this intervention, and that's why we're talking about perhaps the alternative of trying to help them be as comfortable as possible. And then just summarizing at the bottom that we do not have outcomes based on frailty for COVID-19 in Italy or in China. Instead, they did it by age, and there's reasons why that is biased. But still, the case fatality for aged 80 and over in Italy was 20%, which is in the range we see in Canada, and for younger ages was better. So just to kind of focus on the Canadian situation, and this is specific to COVID-19, there is a website called LTC COVID.org, which has different country reports, sorry, spelling mistake there, and they have a Canada country report, and this report was compiled by the National Institute for Aging out of Ryerson University. They've put together our across Canada case fatality rates for long-term care residents who have tested positive for COVID-19. These numbers are not perfect, and the numbers that are being quoted as ones that are the best estimates we have for case fatality tend to be in the provinces that have the highest number of cases, and those are also the provinces that have the most reporting. So in Canada, the case fatality rate for long-term care home residents who are COVID positive is between 26 and 29%. Now, when you go to the country's report on this website, Canada's case fatality rate is quite high, but there are a lot of confounders. And one of the biggest reason is in different countries, the frailty of people in their personal care homes or nursing homes or long-term care are very, very different. So we have a very frail population in our personal care homes. I can't comment on the frailty of other countries, but having worked across Canada, we've got very frail people. And this seems to be a very consistent number of 26 to 29% of people who test positive die from the, during their COVID-19 positive status. So to add to this sort of national summary, I want to share with you some very powerful information that I got firsthand from Dr. Benoit Robert, who is a attending physician at 2 personal care homes in Ottawa and medical director for the Pearly. And he said, I can use his name and the experiences of the Pearly because he never wants anyone else to be making the decisions that he had to make without knowing some of this experience that has gone before. So they had a significant outbreak at the Pearly, which is a large veterans home who also have non-veterans in other wings in Ottawa. Their website is very open about the number of cases, the number of staff, and he shared some of things that he feels are really important for everyone to know. And his case fatality very much lines up with the experience across the country. So they've now treated 21 people with COVID-19 and 9 have died. We're going to talk a bit more about this next week with the presentation, but he said 1/3 of them die with intense air hunger, real respiratory distress, and 2/3 of them died with a more typical, these are people who were tested positive for COVID-19, but had a more typical death, as he described it, for severe dementia or severe frailty, where over a course of days, they were in bed, quiet, not eating, and sort of faded away. The reason why I think this information is important is because this is the sort of information when you're talking about goals of care that we need to know so that we can sensitively describe it to residents and their families when they're asking, well, what happens if I get COVID-19? As far as the situation here, again, may be subject to change, but what we're hearing loud and clear from public health is that COVID-19 is in our region, and there have been rural and urban cases. So the risk of an outbreak is here and could be our personal care home reality at any time, although we're doing everything we can to prevent it. An outbreak will be defined as a single staff member or resident testing positive. That will trigger us to be in an outbreak situation in personal care home. And I have been able to communicate with our ICU leadership, and we currently have the capacity to participate in person-centered discussions. And what I mean by that is Manitoba does not have an age cutoff for access to ICU or any rules about transfers. So we really can talk about the goals of care and focus on what's going to benefit a person without our conversations getting hijacked by people defending the rights for different options. We have the options, and now we need to talk about what's going to actually be beneficial to a resident, or in other tough circumstances, what's going to be futile, what will have no benefit. So another important part of the situation here is what can our personal care homes do as far as supporting non-intensive medical management and comfort care? And again, I have to say this is subject to change, but based on our current situation, comfort medications, including subcutaneous medications, are available, and pharmacy is working very hard to ensure that we have the supplies in case there's a surge in a case in any geographic location, and they're developing backup plans for supply. And they're also looking at our supply of supplemental oxygen, oxygen concentrators, and how they would move them around if we needed a number of them in one place. But intravenous treatments are not going to be offered in the personal care home setting at this time. And, you know, I think there is some degree of question from what we've talked about already with the mortality of whether or not there would be any mortality benefit from intravenous if somebody is so sick with COVID-19 and very frail in the personal care home setting. But the main barriers for intravenous treatment was the staffing, the education, and the access to pumps and pump training. So that is not currently something that's being rolled out as an option. Right now, there is some question about if there's an outbreak, whether or not people's previous CPAP and BiPAP will be allowed, and fans. And again, there's talk about a release of a new AGMP document that'll give us some clarity in long-term care. But in some of the most recent things coming out, they are saying that fans and non-invasive ventilation support increase the risk of aerosolized particles and should be avoided. So I don't think we can include them in the likely menu of things to help people be comfortable if they have severe respiratory symptoms. So that's the situation based on, and people may have other information or questions, but the next thing to update is the information about the resident. So very important if we're entering these is to talk about the most recent discussion about goals of care. So that may include conversations and then also looking at the documentation, because there may be things that the subtleties that didn't get into the documentation about the way the resident or family is leaning. Regardless of how long you've known the patient, it's important to remind yourself of the details. And one of the things that I thought was helpful from some of the recent stuff I've been reading is to specifically highlight in your mind the comorbidities that may get worse if somebody were to survive their episode of COVID-19, but may be more burdensome or more symptomatic, impacting quality of life if they survive. So if they've got symptomatic CHF and they survive COVID-19 and then their CHF symptoms are significantly worse, causing more discomfort, those are going to be things that are important in that decision-making cascade. And if somebody survives COVID-19 but has had delirium and their dementia takes a stepwise decline, or they have more prominent neuropsychiatric symptoms, that's a significant potential quality of life issue. Again, important to ask staff about their recent frailty status. If they're acutely ill, if they're COVID-19 positive right now and symptomatic, it's important to ask about 2 weeks before the acute decline. Same with any acute decline. And then just for more context, it's not about one static number. It's about how have things been changing with their frailty, say in the last 12 to 18 months or in the last 6 months, have things accelerated? Because that also is important. If things are changing quickly, we often say, based on the change in the last 6 months, that can be a predictor of how things are going this next 6 months. So if things have been stable for 3 years, that may suggest more stability going forward. But if things have been getting worse in the last 3 to 6 months, it's important that families know they may continue to get worse. And if there has been an acute change in the resident's status, it's important to know what are the things that are changing. So their mobility, their functional independence, and their cognition, as well as pain, symptoms from other uncomfortable conditions. You know, what all has changed when you're getting an update about the resident. I'm just going to touch again on a little bit more about the significance of frailty, and again, not rigorous journal review, but instead one of my strategies has been to follow on Twitter some of the rock star geriatricians who I think very highly of, have from hearing them at conferences, and they've been tweeting out what they're reading, and I really find that that's extremely helpful with the avalanche of material that's coming out. So Ken Rockwood certainly ranks as one of the rock star geriatricians in Canada, and he actually is the creator of the clinical frailty scale, and he's at KRockDoc. And then he has he's often one of the authors on the frailty publications that are coming out really around the world right now. So he tweeted out a recent publication that his group has published by Pollock et al. And then I found it helpful to see his, pithy summary of what this paper added to the literature. So this paper looked at the role of illness acuity on the association between frailty and mortality. And this is relevant to our conversations with families, because these were people presenting to the emergency room. So you can imagine that they could have presentations similar to what we see in the personal care home, but they may not be transferred to the emergency room. But we have that spectrum of different presentations or different acuity. If somebody had a high acuity illness, their frailty status did not impact their 30-day mortality. So if you're really, really sick, the frailty has less impact on your mortality. But in a low acuity illness, say you get a little bit of gastro, the significance on 30-day mortality is for the severely frail. It's like the straw that breaks the camel's back. They just don't have the physiologic reserve, or they're so vulnerable that they can't take one more low acuity event without it significantly increasing their mortality. In that paper, they defined severe frailty as 7 to 9. So again, just want to provide you some more important information for Dr. Robert, because he actually described a high acuity presentation of some of the people who died in his facility with COVID-19, and then a more low acuity presentation. What he described was that all of the people that tested positive for COVID-19 in their facility were actually tested in the asymptomatic phase. So there was a staff member who tested positive, and then all the residents were swabbed, and they were all asymptomatic, and they became symptomatic after approximately 3 to 5 days from their test coming back positive, or from being tested, sorry. And what he said is, once those oxygen requirements started to escalate, it happened fast. And in the residents who developed this intense respiratory presentation, they died within 12 to 18 hours of that onset of their respiratory symptoms. And again, that was a third of the people who died in their facility, which was 9 of 21 cases. And then the 2/3 who had the more less acute presentation, they took longer. They didn't have that respiratory presentation. Instead, they sort of dwindled, and that took about 3 to 10 days, but they were so frail that they couldn't bounce back from that lower acuity presentation. So the other thing that's very important to update with your information about the resident is the resident's ability to participate in the discussion. And I'd just like to maybe ask you to add to the comments section a couple questions along this information about the residents. I'm just wondering how often, you're really needing a lot of the team support, as we all do, to make sure you've got the current information of the residents, or often do you feel like you know the residents quite well and it's just sort of updating the information that's very recent? And the other thing is how often, when you're sort of getting ready for these discussions, do you feel it's clear whether or not the resident it has the ability to participate in the discussion about care decisions? Is it, most often it's very clear that the substitute decision maker is the go-to? I'm just interested in your experiences. So I'm going to touch on sort of this topic of the resident's ability, because especially with those serious illness discussions, when there needs to be a discussion now, there also needs to be an assessment of the capacity, not exhaustively reassessing their dementia and their MMSE and their MOCA, but I'm talking about a right now, can they participate in their this discussion right now? And I call that a just-in-time capacity assessment. So this is a session all on its own, I have no doubt, but just to summarize it, it starts with educating the resident about the current situation and an introduction to treatment options. So in the case of COVID-19, maybe you're providing 3 small pieces of information: that there's this new virus, and for the sake of simplicity, saying there's this new virus called COVID, and it causes a severe kind of pneumonia for some people, and then quizzing them on that information, and then expanding the information and verifying whether or not they're sort of still retaining the information. And then the pivotal thing is their ability to weigh the risks and benefits of different treatment options. So you can educate about some of it or cue them if they're not coming, but they do have to sort of be able to generate some of the risks and benefits themselves to show that they can sort of weigh those options and have the executive function to participate in the conversations. And then it's very important for you to document your discussion, be concrete about your decision if this decision needs to be made right now, and what your rationale was for the need to go to the substitute decision maker or not. And I think it's important when things are changing fast just to be prepared to reevaluate, because maybe right now they can participate in the discussion, but maybe 24 hours from now, they may not be able. It might be delirium. It might be that they have an acute change in their ability to speak. But just because yesterday they had the capacity doesn't mean that they might be able to discuss it tomorrow. The other thing is you know, it may change where we're saying right now you can't because you're too sick. I'm going to go to your substitute decision maker, but you may regain that capacity. So step 3 is the resources. And I knew this particular day was trying to cram in too much information, but there's some excellent COVID updated material for goals of care discussion. I've put the link to the Canadian Geriatric Society COVID-19 resources because they've been actively gathering information, not just personal care home, but all sort of frail older adult resources, acute care, ethics, behavioral, and they're posting links to those resources. On that page, they've posted 3 Nova Scotia documents that are a partnership between PATH, the Palliative and Therapeutic Harmonization Program, and Nova Scotia Health. And Dr. Rockwood and really Frailty in Canada research is out of Nova Scotia, so it's not surprising that they've incorporated frailty into the their communication support. And like with a lot of things, they have a worksheet and resources for the providers and resources for families and a bit of a script, but they've incorporated frailty explicitly into their conversation. And they have in the healthcare provider information these helpful pictures of how frailty contributes to worsening frailty after an acute health crisis if you undergo standard care. And the other option to be discussed is not pursuing standard care, but focusing on symptoms, knowing that there may be recovery and that recovery may be incomplete, but focusing more on being comfortable during this acute episode. So I'd encourage you to have a look at those resources. The other main resources that are being adapted across the country are from the Ariadne Labs. And maybe you've heard of Dr. Atul Gawande. He's the executive director for the Ariadne Labs and the author of Being Mortal. And they have a set of very open copyright documents that can be adjusted and Fraser Health adjusted. Their serious illness conversation guide, and all of them really advocate, even if you're very experienced at these conversations, getting out your script and filling in some of the information so that if things aren't going well, you have something to go back on. The Ariadne Labs really, you know, emphasizes this is actually sort of a 3-day large program that they encourage people to work through, but they have got a reference guide for clinicians who need to use their resources right away. So I've posted that, but I'm just going to post a bit bigger. It's still too small, but the serious illness conversation guide that Shared Health has adapted from Fraser Health's adaptation. They're all very much in the same themes. You can read them on the Shared Health website, and I'm just going to walk you through how this might look for Mrs. P. So this started as a scheduled goals of care update for advanced care planning as part of an annual care conference, but the situation has changed. Mrs. P is becoming more frail. In fact, she's becoming severely frail. COVID-19 is new and unanticipated risk in our communities. And to be honest, it may have been some changes in Mrs. P's routine because of our measures to try to decrease the spread of COVID-19, and these may be accelerating her frailty. So you're now preparing for this requested change in risk goals of care conversation, and the staff agrees with you because she can't hear and she can't read well enough, and she's having trouble retaining details and really problem solving because of some underlying dementia. It's appropriate to have this conversation with her daughters on her behalf. So the script that might sort of be prepared, you know, again, I think that having this script is helpful. So step one is setting up the conversation, reviewing the purpose. I'm glad we're having this opportunity to follow up on the annual care conference. So mentioning that you're building on the previous meeting that was with the team. Step two, assessing, understand. Just get an idea where they're at after the annual care conference. What was your understanding of how your mom has changed since you last saw her back at Christmas? And you may need to sort of review some of the information from the annual care conference if they come back saying she's doing great for her age. You know, what people hear sometimes is not what we thought we said. You know, if they don't mention that she's becoming frailer, then it's time to go back a little bit and review what was said. But maybe they're saying, you know, we hear that she's not doing as well. And then you could ask about how they feel. Her frailty may impact her outcomes if she were to become sick or need intensive treatments, because one of our goals of this conversation is talk about COVID-19, but also one of them may be the fact that she still has resuscitation as her goals of care. Step three is to share the prognosis. And this was one of the pearls that I've taken away, and it's been mentioned in just about everything, including the excellent Pallium webinars. So they've made those free and open access. If you go to the Pallium website, that's a great Canadian palliative care resource that's offers courses, but then is really trying to support palliative care during COVID-19 in Canada. So I like this I wish, I worry, I wonder, and I'm going to try it out here for Mrs. P. I wish your mother wasn't becoming frailer when there's the risk of COVID-19 coming to our communities. I hope COVID-19 never comes to our personal care home, but I worry your mom would be at risk of getting sick and dying if she did get infected. And you know, they really do say it's important to explicitly bring up dying because people may not hear, you know, increased mortality or severe respiratory distress may just not register. I wonder if she would want us to ensure she's comfortable if she knew that transfer to the ICU and breathing machines would not improve her chances of surviving. And if she did, she would lose yet more strength and independence. So this is planting the seed and then using the information that you've gathered about how frail, you know, if the family comes back sort of defensive or sort of challenging you, what do you mean? We've heard that people who get ventilators with COVID-19, you know, that's the best chance of surviving. Then you can sort of talk about how she, being frailer, would not have the same chances of survival as other people who have been making it out of the ICU. The other things, and in the interest of time, I'll stop there, is step four. And I like how they specifically say between step three and step four to allow for silence, especially on these telephone calls, because you get these delays. You don't know if you've been cut off, but, you know, just to give them a chance to process and then explore the key topics. Step five, provide reassurance. This is when we can talk about everything we can do to help with comfort. And then step six, close the conversation. And important to verify what you think you heard and then document that as far as the family's wishes on Mrs. P's behalf. So in conclusion, there are a lot of opportunities to discuss goals of care that may present themselves, and sometimes we have to make them happen. Some preparation is required to have a people-centered discussion about goals of care, and it takes a team to be prepared to provide those care, care consistent with the personal care home's residents' wishes when it's necessary. And I say when it's necessary because for our personal care home residents, we are going to need and want to care for them through end of life. And the residents and their family may not know how frailty affects the outcomes of diseases and success of treatment options. And having a script, even if you're very experienced, is important, preparing for even routine goals of care conversations, but then you're used to them. It doesn't feel as weird when you're getting into more intense interactions. So I'll just, I'm going to include another website that I didn't work in, but Vital Talks, which sort of talks about, again, options of how to phrase some of the more difficult conversations around COVID-19. And this is the information about the copyright from Ariadne Labs. So now let's just pause for any questions. You can unmute yourself specific to today's talk. And again, my grand plans of having time to go off recording and talk about bigger issues in the personal care home hasn't happened. I'm just going to scroll through the chat to see what's come up as far as questions. Anybody go ahead and just speak up. So there's been great discussion, and I'm looking forward to getting this. I'm looking for anything that jumps out with a question mark, but thank you for all of you who have contributed.
Okay.
So if there, go ahead, Dr. Mayer.
How do you handle families that are very insistent on ACPR or aggressive ACPM in a patient that has, you know, a high frailty score?
So, you know, often I have the benefit of being sort of on the second opinion side of things. And what I can sort of get an idea right off the bat is, where are you coming to from this discussion? And one of the things that I like to get into is, why did they want that? Because often there's a backstory, you know, somebody who miraculously survived, you know, or even the survivors of CPR who then are like, well, I survived before, I'm going to survive again. You know, often there's a bit of a backstory. So finding out, was there, and sometimes there's a fair bit of anger, was somebody withheld? Did they perceive neglect at some stage? And then you can sort of talk about how this situation is different. And then I think a lot of people, there is a lack of, the families just haven't heard or don't know about the two things. One is how frail the person is becoming, and often if there's underlying dementia, or if dementia is their primary thing, that's actually a terminal diagnosis, and what dying with dementia looks like. We can often make people comfortable, but they may not know what that looks like as it gets worse. So I think explicitly talking about frailty, and some people become quite defensive. Yeah, but they're doing really well for their age. Yes, but look at how things have changed. So shifting away from a list of underlying conditions and more to that frailty, it's a bit of a roundabout long conversation, but often it helps them understand that we're not going to prolong this forever. And then you can introduce the outcomes in somebody who's severely frail, because they'll then have a clearer picture of how their family member, what that would look like, the dying in those intensive situations, or what their survival would look like afterwards. All right, Jocelyn, let's turn off the recording, and look at that, I do have 5 minutes. We'll turn off the recordings. If there's anything